Okay, well, welcome to class. Finally, we get to meet almost face to face, And for those of you Zooming, welcome also. I hope you can, if everybody can hear me, I hope. Let's see. Okay. I'm going to pass this around and just go ahead and put a check mark by your name. And those of you online, I've already marked you as attending. So, and for Tuesday's class, I already reported everybody as attending, so you should have no issues with Morristown over that. And I'll be doing that for the next couple of weeks, but I'll be taking attendance. I will tell you, I don't ding anybody if they have to miss. We didn't cover that. Somebody asked me a question yesterday. Do I take off for missing class? I said, no. Why should I do that? Because things are going to happen. Our lectures are all recorded. Did everybody get to see the lecture? Or did they check did the Zoom link work? Good. So I'm always afraid I'm going to send the wrong Zoom link out to somebody. So, but if you miss the class, you miss the class. You have things to do. You can't go back and make up the class, but you can watch the class on the Zoom. So I'm not going to ding anybody for missing the class. The same thing applies to lab. Our lab on this coming Tuesday will be probably about as populated as this, and we'll be doing some stuff hands-on, and people on Zoom can watch that. But if you can't make it, that's the other advantage of this class is if you can't come to class, you can always come in by Zoom, and it's your option every day. So I just didn't expect the first day of class to be a Zoom class. So I thought I was done setting in my office at home, but I guess I wasn't. Anyway, okay, so we've had one class in now so far to cover the first part of the first chapter. We got almost halfway through the first chapter. Any questions on anything? Any questions about the class? Or was it just so exciting you just couldn't wait to get here this morning? Yeah. Oh, okay, thank you. Okay, that's great. So, and I realize that this is probably not the most exciting stuff to start out A&P with, but once we get through it, it'll start getting better. Trust me. So let's go ahead and open up the PowerPoints. And let's get this in place. Okay. So everybody should see the slide, requirements for human life. I did this right. And of course, we can see it here too. Now, when we stopped the other day, we were just about right in this area here. I think if I go back one slide, we were, I think we talked about growth and development and reproduction. I think this was the last slide we talked about in here. And we were getting into what do we need to survive? It's it's great that we have a space station. It's great we're going back to the moon in a couple of years, but the only way we can survive in the space station, the only way we can survive on the moon is if we bring all of these things with us. They have to bring their own oxygen and food and water, the things that we take for granted here. Nobody stops to think about, well, do I have enough oxygen in the classroom? Well, hopefully we all do. Nutrients. Hopefully we ate something this morning. We're drinking something. You've got, I've got coffee. You didn't have to push it away. It's okay. So, so, and as I said the other day, if you're in the classroom, you don't have to worry about bringing something in. It's okay. So, but these are the things that we take for granted that we have to have an abundance of to survive. We have to maintain, as I said, the right amount of oxygen. We have to have food. We have to have water. We can only live for 3 days without water. 72 hours is the limit before we die without water. And the last 24 hours are pretty exciting with emotional breakdowns and stuff like that. So body temperature, we got to maintain a body temperature. We don't want to get too hot or too cold, and we have to have enough pressure in the air to have enough oxygen in the air. Now, that sounds convoluted, but I'll explain that here. So oxygen, atmospheric air is about 20% oxygen. That's more than enough for us. You know, we breathe in atmospheric air, it's 80% nitrogen, 20% oxygen, and more or less, there's some trace gases in there too. And we breathe out about 16% oxygen. You know, when we exhale, we only use about 4% of what's there. So there's, you know, at a 20% level, there's more than enough oxygen for us. Nutrients, we got to have carbohydrates. We got to have the starches, the sugars, the pasta, the things we like. We got to have that for energy. We have to have protein to build our muscles, to make our muscles larger, and to wrap fibers around our bones, for example, to make them very resilient. We have proteins for all of our enzymes that control our chemical reactions. We have to have proteins. Fats, you know, fats get a bad reputation and a bad name, but we have to have fat because that's where we store our long-term energy. There's more energy in a gram of fat than there is in a gram of carbohydrates. We get 10 calories per gram of fat versus 4 calories per gram of carbs. We got to have minerals. We got to have vitamins. If you take a multivitamin, that's great. If you take more than one multivitamin, that's not so great. We'll talk about that in the second unit. You know, vitamins are one of those things that if some is good, more is not better for us. Minerals, we have to have iron. Why do we have to have iron? Why do we have to have iron? Exactly. Thank you. Red blood cells that carry all of our oxygen are based on a protein called hemoglobin. And hemoglobin has iron at its center. We have to have iodine. Iodine allows our thyroid to make a hormone that controls all of our metabolic activity. Where do we get iodine? Anybody ever eat salt? Salt has iodine added to it. About 100 years ago, they started adding iodine to salt because there was this tremendous iodine deficiency in the US. People were getting their thyroids that would grow up to be the size of a football under their neck. You know, it's like, trust me, you'll see the pictures in AP2. But they all went away because they added iodine to salt. Everybody uses salt. The only salt you get now these days, it doesn't have iodine, and it's sea salt. There's not very much iodine naturally occurring in salt to begin with, and sea salt has even less. Those are two minerals, and yes, I know they're elements, but those are two minerals that we have to have in our diet. With no iodine, then our metabolic rate plummets, and we just sort of sit in the corner and sort of go in and out of consciousness because we don't have any energy. Iron, we don't make a lot of red cells if we don't have iron. Okay. With water, we are about 70% water. All of our fluids in our bodies are based in water. Our plasma that carries our red cells is nothing but salt water and some proteins thrown in. So our blood's about 55% or so water. You take a sample of blood and let it set out for a couple hours. The red cells all move to the bottom of a test tube, and the rest of it is all salt water. We call it plasma. So our bodies are about 70% water. You know why old people wrinkle up? We've all seen old people. When elderly patients, let's say it that way, have wrinkly skin, you know why that wrinkles? Lack of water. Their body water is only about 40 to 50%, as opposed to a young or middle-aged adult. You know, so when you see these wrinkles, you know, it's because of a loss of water. Because we've all seen that. You know, if you're in water, if you're in the pool for a long time or in the ocean, You know how your skin, your fingers, they get all wrinkly? It's because of they are losing water to the outside. So we get, that's what happens. We got to have a lot of water. We use water for cooling. What do we do when we get hot? Well, yeah, but what else? Yeah, we sweat. Thank you. Yeah, I mean, of course we drink cool water. That's no matter what they tell you on advertising about drinking a Coke when you're hot and thirsty, you know, or a beer or anything like that. And it's hard to beat either one of them when they're ice cold. Did I say that out loud? There. Okay. They don't quench your thirst. Water is ideal, but you know, we also perspire. Water evaporates off our skin and it cools us down. And that gets us into body temperature. Body temperature, we try to keep it right at 98.6 or 37 degrees Celsius. I want to make sure it's the right number up there. So, and I'll say that, you know, you'll be so tired of hearing me say 98.6 or 37 degrees Celsius. I don't know, I've gotten in the habit of saying it. Anyway, that's a normal body temperature. All the chemical reactions in our bodies are designed to operate at that temperature. We like that temperature. We like 98.6. So when we make proteins, they're designed to operate at that temperature. We don't like to get too cold. If we get below 94 degrees, bad things happen to us. You know, it doesn't take much to kill us if the temperature drops. The same as the temperature gets above about 106. That's bad things happen there. The chemicals start breaking down, and you know, cells start breaking down. So we don't like to be above or below this normal range. And air pressure. Air pressure is very important to us. At sea level, and we're about 1,000 feet above sea level right here, the air pressure is 760 millimeters of mercury right now. 20% of that is oxygen. The pressure in that at sea level or thereabouts is made up of the pressure of the nitrogen in the air and the oxygen in the air. And so 20% of that is from oxygen, which is about 160 millimeters of mercury pressure. And so that's fine. But if we go up 10,000 feet, if we go to Colorado, if we go to Estes Park, Colorado, which is sort of the counterpart to Gatlinburg, because you know, Gatlinburg is the entrance to the Smokies. Estes Park is the entrance to the Rocky Mountain National Park. 10,000 feet elevation. The air pressure at 10,000 feet is exactly half of what it is here. And that means the amount of oxygen, the pressure from the oxygen is no longer 160, it's only 80. And that pressure is caused from the little air molecules bouncing around on you. Well, it's half as much as it was. And that is the limit of what you can do, move around with without becoming unconscious. It all has to do with the amount of oxygen in the air. The higher up elevation we get, the less oxygen there is for us. It's still 20%, but it's less pressure. You know, you've probably heard of it. You know, aircraft are pressurized. You know, so you fly and you're at 35,000 feet or something, and you're pressurized. And they always give you the warning if we suddenly depressurize, a little mask will drop down in front of you. You know, has anybody ever had that happen to them? That's good. So. Well, because we can't survive at 30,000 feet. You know, at 10,000 feet, we're cut in half. At 20,000 feet, we're cut in half again. At 30,000 feet, we're cut in half again. You can't survive unaided at 30,000 feet or even 20,000 feet. So we have to have enough oxygen and air pressure to be able to breathe. So, and we'll get more into that when we get into AP2. Okay, there's a term here. You're going to be tired of hearing me say it. And I promise I'll stop saying it in AP2. It's called homeostasis. Homeostasis, an easy term for that, remember, is the status quo, or just maintaining a balance. You know, we want to stay at the same constant for all these different parameters. If we get too hot, we're going to sweat to cool down, because we don't want to be above 98.6. If we get cold, we're going to shiver. because we don't want to be below 98.6. We want to be right at that level. If we get hungry, we're going to eat. If we get thirsty, we're going to drink. Our bodies will constantly adjust and adapt to maintain a constant balance of pressure and temperature and water and nutrient levels and oxygen levels in our bodies. If our oxygen level gets a little bit low, we'll breathe faster. We'll breathe to bring in more oxygen. Or even better, our blood cells will release more oxygen. So how we do this, there is a mechanism very simply called negative feedback. Negative feedback is actually, even though it sounds bad, negative feedback is a good thing. Negative feedback depends on three parts. It has a sensor that monitors your temperature, for example, or your blood sugar level in your body, or oxygen levels, things like that. We're going to have a sensor, a receptor that monitors things in our body. We're going to have a control center that tells us what it means, because receptors in our bodies can't tell us what's going on. A touch receptor can't tell us what's happening. It can only be stimulated and sends a signal to the brain. Your eyeballs have no idea what they're seeing. All they do is collect light rays and generate nerve impulses. So you can't, all these receptors, temperature receptors, no idea what they're responding to. But they send a signal, they send a nerve impulse to the brain. The brain processes as, hey, I'm hot, or I'm cold, or I'm thirsty, or, oh, that's a stop sign, I better stop. A little faster than that, though. So that's the sensor, the control center, and what we call the effector. How do we fix the problem? The problem is we're hot. Sensory receptor in our skin has been activated, and it is turned on for heat, because we have temperature receptors for both heat and cold. So we get hot. The receptor is activated. It sends a signal to the brain. The brain processes that signal and says, oh, we're hot. And it sends a signal out to the effector, a sweat gland, and says, sweat. So we sweat and we cool off, and our temperature drops. And once our temperature drops, then we stop sweating, because the receptor is no longer being stimulated. So we use these types of mechanisms for everything in our body to regulate temperature, pressure, and hunger, and thirst, and sugar levels in our blood, and oxygen levels and carbon dioxide levels in our blood, and all sorts of things like that are done through negative feedback. We call it a negative feedback loop. What the negative feedback loop does is it reverses the stimulus. If the stimulus is you're too hot, it reverses it to cool you down. If you're too cold, it reverses it to warm you up. If your blood sugar goes up too high, you ate a donut this morning, or an apple, or a bowl of cereal, or whatever, but it had carbohydrates in it. The carbohydrates go into your blood. Everything that we eat and drink ends up in our blood. And the carbohydrates in what you ate end up as sugar in your blood. And that raises your blood sugar levels. Well, it raises the blood sugar up higher than what it should be. I mean, that's perfectly normal. When you eat something with carbohydrates, you're going to bring your blood sugar up. It's not a bad thing, Don't stop eating apples or donuts. And no, Dunkin' Donuts doesn't pay me to say that either. So, but your blood sugar goes up, your body releases insulin. Insulin allows that sugar to go into your cells. And once the sugar goes into your cells, it leaves the blood, and the blood sugar level drops back to normal. And we stop releasing insulin. You've all heard about insulin, right? And you've probably heard, blood sugar, diabetes. Anybody ever heard? A lot of people still call it sugar diabetes. Have you ever heard that term? Yeah, it's a very common term that's been around for a long time. But that's how we fix it. We release insulin from our pancreas down in here, And that opens up the cells. The cells suck in the glucose, suck in the sugar, and the sugar levels in our blood drop, and then we stop releasing insulin. Just, that's the negative feedback loop. Just like this, our body temperature is above 37 degrees. So our temperature receptors detect that, sends a signal to the brain. The brain tells a signal to the sweat, sends a signal to the sweat glands. We sweat and we cool down. So it's a negative feedback loop. It reverses the stimulus. I think I just said all that. So body temperature and blood glucose, that's what we call blood sugar, is blood glucose by insulin. If we're cold, we shiver to warm up. That's negative feedback. If we're thirsty, we drink water to reverse the stimulus for thirst. And that's negative feedback. So just about everything we do in our bodies is controlled by negative feedback. And, if you like really busy slides, you can. This is really busy. It shows you if our blood glucose level goes after eating, we release insulin and bring it back down. Conversely, if our blood glucose is low, let's say that you were in such a hurry to get here today that you forgot to eat. You just couldn't wait to get here. So, you forgot to eat, but your body still needs sugar for energy, because sugar is the molecule we use for energy. We don't use fats for energy initially. We use sugar, carbohydrates. So if our blood sugar is too low, we release another chemical called glucagon, which tells the liver to release sugar in the form of glucose. That goes into the blood. Then we release insulin, and then the glucose, the sugar, goes into our cells. And so while you may still be hungry, your cells at least are getting fed. It doesn't do anything for our hunger, but it will at least make you feel, your cells will feel better. Those commercials that they used to show with Betty White, you're not yourself until you eat a Snickers bar. Everybody see that? Yeah, Well, the whole basis of that is that the carbohydrates in the Snickers bar provided some energy. And I will say a Snickers bar is a pretty, for a candy bar, it's not bad. It's got protein in it with the peanuts, and it's got a lot of carbohydrates, probably a little more than we need, but probably not a lot of fat in it. And so for a snack as it goes, it's pretty good. What they were trying to say is that when you ate the Snickers bar, you got the boost of energy from the carbohydrates. Because you were hungry, you ate this, your blood sugar went back up, and your cells had more energy to do things. So it was not a bad idea. Of course, the commercial took it a little further than you should, but they always do. But anyway, the point was that we eat something, we generally feel better afterwards. Now, if we have a negative loop, and something you're going to see in A&P is if we have a negative, we're going to have a positive. If we have a top, we're going to have a bottom. If we have a front, we're going to have a back. We always do. And here we have the positive feedback loop. And the positive feedback loop is not good. There are positive feedback loops enhance the original stimulus. They make it worse. If you get cold and you shiver so much to warm up that you sweat, you'll start cooling down again. There's a condition known as hypothermia, where you get very cold and you deplete your body resources, and then you die. From being, they say you die from exposure. And most people think that someone's like frozen to death in a snowbank or something, at 30 below. Well, most people die from hypothermia about 55 degrees outside. They got wet, they got cold, the water that they from getting wet, they fell into a river or something that got wet, and that lowers their body temperature, so they shiver to warm up. They shiver so much they sweat, and they cool down, and shiver some more. It just gets worse and worse, and then they die. Well, most positive feedback loops like that are a very bad thing. There's only two that we can think of that are, well, actually, there's three. Childbirth. Baby's head presses against the cervix, the mouth of the uterus in the female, pushing against the cervix causes the release of a chemical which stimulates uterine contractions, and it pushes the baby towards the opening. That contraction causes the release of more of that chemical that causes the contraction. So you have more and more chemical and more contractions that are stronger and stronger every time until delivery. That's positive feedback. Same thing with breastfeeding. The more the baby sucks on the nipple, the more milk the baby's going to get. Same chemicals involved for that causes the contractions during delivery. Those are both positive feedback mechanisms. Same with blood clotting. When you have an injury and you're bleeding, the clot formation to stop the bleeding gets bigger and bigger and bigger as it goes along until it reaches a point where it stops it. So those are about the only three positive feedback mechanisms that are any good. The rest of them are all bad for us. So we hopefully don't get into those. We don't want our patients to be exposed to any kind of situation where a positive feedback mechanism would make things worse for them. So, okay, and I keep getting ahead of myself, but that's okay. So, childbirth, positive feedback loop. We're talking vaginal birth. Cesarean doesn't care because we take the baby out. And the same with clotting. Blood clots form through a positive feedback loop. The bigger the clot gets, the more clotting fibers it's going to bring in with it. So those are both good things. Okay. We don't like to stay out of balance. We like to maintain homeostasis, and we don't think about it. Nobody walks around thinking, "Oh, I better stay in homeostasis today. It's not going to be a good day if I don't." Nobody, and I'm sure that nobody even heard the term homeostasis. So I mentioned it today. Anybody ever hear the term before? You have? Okay. So I'm wrong always, so it's okay. So that's good. Homeostasis is our normal status quo, set point, whatever. But when we get out of balance, and we're not talking in like a homeopathic way or anything like that, but when our temperature gets too high or our temperature gets too low, if our blood sugar levels get too high or too low, we run the risk of some sort of pathological state developing. A person who maintains a very high sugar concentration in their blood may become a candidate for diabetes. And we have in East Tennessee, and in the South in general, but particularly in Tennessee, and it seems like East Tennessee is the leader in this, we have a lot of cases of diabetes in Tennessee. We also have a lot of obesity, and obesity and diabetes tend to go together because a high fat, high sugar diet often leads to diabetes. It also often leads to heart disease. So there's lots of things that work like that. So if we're out of balance on our weight, on our blood sugar levels, on our hemoglobin levels, we are always at risk for some sort of disease state that can occur. So, a pathogen is a disease-causing microbe. It can be a fungus, it can be a bacteria, it can be a virus. And who hasn't heard, well, when you're run down, you have a greater risk of getting sick, right? We've all heard that. We were probably preached at when we were kids. And while most old wives' tales are just that, some of them actually have a basis. In fact, a person who doesn't maintain a healthy diet with exercise and stays within the boundaries of the requirements that our body requires, same thing, is a person who stays in balance is much less likely to develop some sort of disease. Now, it doesn't explain why, healthy people get cancers or healthy people develop heart disease or things like that, but it does explain why people who have excessive levels of blood sugar often develop diabetes. So heart failure is a preventable disease in most of the population. While there are some people that develop heart disease through genetics, that they're prone to heart disease, most people develop heart disease through their lifestyle choices. And unfortunately, with heart disease and high blood pressure, for example, they're the kind of conditions that develop slowly over time. It isn't something that you eat a cheeseburger and the next day you're going to have suddenly you have heart disease. It's probably the end result of thousands of cheeseburgers. There's nothing wrong with cheeseburgers, in fact, I'll say there's nothing wrong with anything in moderation. You can eat anything you want. You can drink anything you want in moderation. It's when we eat excessively or drink excessively or exercise excessively, because it works both ways, that we get move out of balance and we're more prone to disease states. When we talk about bones, for example, we'll talk about how obsessive exercise can lead to a disease state too. So, again, if some is good, more is not necessarily better. So, now, I showed you the other day the person that had decided to eat 87 nails. Remember that one? The X-ray. And I said that X-rays are great for bones and for solid objects. If you want to see where there's a fracture, you want to see if somebody swallowed something, X-ray is great, but it doesn't help you for soft tissue. Let me just go back real quick to that X-ray picture. There we go. I just like looking at the nails. So, you can't see anything here except the nails. You can see the spinal column. You can see the hip bones. And that dark area in there is the large intestine. And the only way the large intestine is visible was to be inflated with air. So, but everything else, all the other soft tissue is not seen. Soft tissue doesn't reflect X-rays. Yeah. But there are other mechanisms that are non-invasive. One of the ones we use a lot in healthcare is the PET scan. And PET scan, positron emission technology or proton, whatever it is. It is a mechanism particularly useful for looking at cancer cells and tumors. It usually involves a dye that the tumor sucks up, or a dye with carbohydrates in it, because cancer cells love glucose, love sugar, and so they will track that in easily. And so you can use these PET scans to identify the location of a tumor or multiple tumors, while an X-ray of the chest may show a cloudy area where a tumor is. And that's all because it's still soft tissue. A PET scan allows you to see exactly where the tumor is, where its shapes are, and how far it's spread. In fact, this one up here shows you a tumor there in the chest, and also up in the neck. A little white dot up there is also a malignancy because it has spread. It's probably lung cancer that has spread to one of the lymph nodes in the neck or the cervical region. The big white blob there at the bottom on that slide is I get this. Let's see if I can get this to work. Oops. this, so excited, finally worked. Could never do that at home either. So that is the bladder. And usually when you get a PET scan, you'll see the kidneys highlighted. In fact, you can sort of see the kidneys right in here highlighted. You'll see, you'll see a lot of these as we go on. You'll see the kidneys highlighted and the ureters and the bladder. That's not where the cancer is. That's just where the thank you. The dye is going through. But what it does is it shows you different locations. You don't. It's non-invasive, because it is. Non-invasive techniques are ideal because surgery is a trauma to the body. Surgery is necessary. Surgery is important. We have to have surgery for lots of things, but it's always a trauma to the body. Body doesn't. Most of us, if you've ever had surgery, you recover from the surgery depending on what it is. Maybe it's outpatient. Maybe you're in the hospital for a couple days. Whatever. It's still trauma to the body. And exploratory surgery is a term that it's like, what are we looking for? Well, we're not certain. We're just going to look around, and that is, at the very least, unpleasant for the patient. With these scans, we can go in and look without having to open them up. Only go in and see what we really need to see. Anyway, moving on. Anatomical terms. And this is something that will be useful for you from here on out. We don't use terms like left and right and up and down too awful much because it has different meanings. And when if I say I'm holding up my right arm, well, if you're looking at me, what does it appear to be holding up? My left arm, because it's your perspective. Now my left arm goes up, and to you it's right. But I draw a picture of the heart on the board or on the screen here. The way I draw it will always have the right ventricle on the left side of the picture, because I'm drawing the heart as we would see it looking at it in the body. But your perspective is wrong. My perspective is wrong because we're seeing it. We're looking at it as we see it. So you don't want to say, well, there's damage to the right ventricle and they go to this side. Well, it's not any good. So we have to use proper terminology to describe things. So directions mean something here. And there's not a lot to learn about directions. There's only a few terms we need to remember. Now, the number one thing is the anatomical position. The anatomical position is right there in the slide. It is standing upright or on your back flat with your feet apart and your thumbs sticking out to the sides. This is the anatomical position. This is a standard position. If you're examining a patient, or if you're involved in surgery on the patient, or if you're just opening up a cadaver, that's the standard position that they're going to be in. And if you say anatomical position to anybody in healthcare, they're going to know what you mean. So it's a constant for everybody. But to maintain this consistency, we use terms that everybody uses. So we would use terms like lateral and medial and dorsal and ventral, superior and inferior, as opposed to up and down and left and right, because they mean different things. So here are the terms: anterior and posterior, front and back. Anterior is in the front, posterior is in the back. That's sort of easy to remember. But anterior also means ventral, so that your belly side is the ventral side. Posterior also means dorsal. Think of the dorsal fin on a shark. or on any fish. That's their backside. You know, he took the fish and stood it up, the fin sticking out in the back. So anterior and posterior. Anterior is the front, posterior is the back. It's also ventral and dorsal. Superior and inferior. Superior is above, inferior is below. You know, and that's, you know, you can say that the part is inferior to the throat, because it says, it's a complicated way of saying the heart's down below the throat, but you would say head superior, foot's inferior, you know, above and below. The one we use the most, medial and lateral. Lateral means away, to the side, far away, you know, off to the side. Medial means close to midline. Medial and lateral. And we'll use those all the time, particularly when we start looking at bones and looking at muscles. We can identify arms and legs. We can identify the medial side of a leg or the lateral side of a leg. We can identify the medial surface on a bone, the lateral surface on a bone. Those are constants. Those are always a constant. If I say the lateral side of the leg, it's always on the little toe side. If I say the medial side, it's always on the big toe side. Things like, you know, medial near the midline, lateral away. So those are terms that we will use all the time. You can even see it right here on the illustration. Medial near the midline, lateral to the outside. That's probably the one. That one and dorsal and ventral are probably the ones we use the most. And don't worry about trying to memorize all this at once. You're going to, particularly in lab, you're going to hear these terms again and again and again. And by the end of the semester, you'll have a pretty good handle on most of this. Never like this slide. So now, something else, the way we divide the body up is both into the axial and appendicular divisions. The axial skeleton, all the bones run in a vertical axis. So that would be the skull, the vertebrae, the ribs, all the way down to the tailbone. Is this still working? Oops, no. All the way down to the bottom of the spinal column. All of this, the ribs, the sternum, the vertebrae, and the skull are all the axial skeleton. Everything else is the appendicular skeleton for the appendages, for the arms and legs, hands and feet, fingers and toes. Everything in pink over there is the appendicular skeleton. So we have two big divisions here within the body, axial and appendicular. And when we talk about bones in lab in a couple of weeks, we'll be going first through the axial skeleton and then through the appendicular skeleton. Now, if we look at body parts, there's a lot to remember. And eventually, by the end of the semester, you're probably going to know most of these. You're not going to, don't worry, I'm not going to test you on these on the first test. However, some of them you may already know. Cranium. Who hasn't heard the term cranium for the skull? Or the digits for the fingers and toes. Or let's see, patella, the kneecap. That's on the list here. The femur, or the abdomen, or the cervical region of the neck. So a lot of these terms are ones we already know. I know it looks like there's a lot of terms there, but it really isn't as bad as it looks. Gluteus, for the butt, gluteus maximus. And when we get into muscles, we'll discover there's a gluteus medius and a gluteus minimus also. The calf muscle, another name for that. Calcaneus, the heel of the foot. So a lot of these terms are, abdomen. Abdomen's on the list here. Umbilicus. Who doesn't have a belly button? Hopefully we all have a belly button. So if you don't, let me know. All these terms we're going to come to use throughout the course of the semester. So don't worry about learning them all at once. You can't. There's just too much there. However, I will tell you that there is a term that you probably need to remember for the final exam, because our final exams are composed by all the A&P faculty. We all contributed questions, and they got thrown into a big test bank, the ones that made the cut, and they went into a big test bank. But there's a question that always seems to show up all the time. Somebody really likes the term for the thumb and the big toe. Pollex over here is the term for the thumb. Don't ask me why Don't ask me why it's in the final exam. And halux is the big toe. Pollex and halux. Now that's a hard-hitting healthcare question. How many times has someone come up to you, or someone will come up to you and say, "So tell me about that halux. What do you think? What's going on with that?" So I don't think so. But if it gets you a couple points in the final exam, I'm not the one to stand in the way. So, anyway, okay. So all these terms here describe areas in the body. We've used them all, or some of them already. Who hasn't said ocular for something with the eye, or nasal cavity, with our nose, So just a lot of these are just variations on terms we've already heard. This is the Latin root for most of those words anyway. So anyway, moving on. We can look at the body in several what we call planes. Imagine if you had a specimen that we had separated by this huge sheet of glass right down the middle, from front to back, or left and right, or top to bottom. So when we look at slides, for example, we look at specimens, they're going to be found usually in one of these three planes. It's either going to be a sagittal plane, which divides into the left and right. You could right down the middle, like you see here. The darker green one, I guess, giving you a left and right cut. A frontal cut gives everything front and back, or anterior and posterior, and a transverse cut, which is what we call cross section. Who hasn't used the term cross section? We've all heard cross section. Well, a transverse cut is a cross section. It can be anywhere. It can be the middle, it could be here, it could be down by the knees, it can be by the feet. Just like a sagittal cut can come down the middle or just through the elbow. And a frontal cut can be the tip of the nose and everything behind it. So we have these three planes that we can use for identifying locations on the body. So sagittal plane, frontal plane, and transverse plane. So the sagittal plane gives you a left and a right. If it's a mid-sagittal plane or mid-sagittal cut, it's right down through the nose. If it's anything else, it's a parasagittal, and so it can be off to the side. Because sometimes when you're looking at looking inside an individual, the problem may be on this side and not over here. So a cut down the middle, electronically, isn't going to help you. And a frontal cut gives you an anterior region and a posterior region. It can be right down the middle, right through here, or it can be through the nose, or it can be through the back of the skull. And then the transverse is what we call the cross section. Now here we see this is a mid-sagittal cut with an MRI, magnetic resonance imagery. Probably the gold standard as far as imagery goes to identify the soft tissue. And the cut is made right down the middle of the body. And what we're looking at is we can see the vertebrae, we can see the rectum, we can see the large intestine, we can see part of the abdominal wall there in the front. And so it just gives you a nice view of what's going on inside, all the way up and down, giving you a left and right perspective. This is a CT scan, which is also a very good mechanism of a penetrating injury to the heart, a roofing nail. See, and this allows you to see not just the vertebrae, but also the structures of the heart, as well as the ribs and the skin layer. This is probably part of the gown or whatever. But you can see structures in here. You can see some of the chambers of the heart, but you can see the location of the roofing nail. It was one of those situations where, is this thing loaded? Type of, it's survivable. The person survived this. Penetrating injuries to the heart often close up around the injury. So while it does look like, it is a very serious condition, it was not fatal. Because it didn't go all the way through, it didn't cause a great deal of tissue damage. Those kind of penetrating injuries are very survivable. That's why, paramedics are taught, don't pull the knife out of the heart. If there's a knife sticking in their chest, don't pull it out, leave it in, stabilize it. In AP2, we'll talk about the heart. I've got a great image of an arrow sticking out of somebody's chest. I guess they didn't know the bow was loaded either, but so they survived that too. So the heart is a lot more resilient than we give it credit for. If you look at TV and movies, it's like, well, they're shot in the chest, they're dead. We've all seen that. You're dead. Well, not really. Sometimes it depends on a lot of things. So, but the CT scan shows you exactly where this object is. Now, frontal cuts, frontal plane, coronal plane, either one. Now we're looking at front and back. We can see the lungs now. We can see the location of the heart. We can see the liver. We can see the stomach and the spleen. This is a great image here. You can look at the lungs and see, is there something wrong in the lungs? Is there something wrong with the heart? Is there a tumor growing on the liver? Do we have an aneurysm in the blood vessel? How big is it? What's going on? We can even see the heads of the bones here, and here. Then on the top of the where you can see where the shoulders are, you can see the heads of the humerus right on in this. So you could look at a lot. You can get a lot out of this image. You could do a scan of the gallbladder to see if there are gallstones there. Gallstones are easy to detect. Anybody know how most gallstones are detected besides pain? You know what a gallstone is? Gallstone is it's like a kidney stone, only it's in your gallbladder. Okay. Ultrasound is so good for now that you can put the probe over the gallbladder and you can see if the bile duct is blocked, if there are kidney stones, if there are gallstones in the gallbladder, simply using sound. Same type of ultrasound we use for looking at babies, we can use for that, but this is even better. So, and this is the cross section or transverse cut. Here we're looking at the liver and the spleen, and we're looking right down into it. with the liver on the right-hand side and the spleen over the left-hand side. And the image is backwards for some reason. Should be flipped around the other way, but everything's still labeled correctly. Because our liver is not on the left side, the liver's on the right-hand side. But you can look at the aorta. If perhaps the person has an aortic aneurysm, a bulge in the aorta, you can see it right here. Perhaps there's something, they have a fatty liver, for example, or the bile duct is blocked. And you can see all this. You don't have to have any kind of invasive techniques yet. So, okay. This is a CT scan of the brain. And it's at the level of the eyeballs. You can see, in fact, if you look at the eyeball, you can see. Come on, there we go. Come on, okay. Right here is one of the eyeballs. There's the other eyeball. Let's get you out of the way. You can see right in the front of the eyeball, you can see that's the lens. You're seeing that little dark oval shape in the front is the lens of the eye. And you're looking at the brain about mid-level in here, looking for things that are out of place. And it's convenient that circle I drew earlier is actually falling on the right spot there, because there is something going on the right-hand side there that we don't know what it is. Now, this next one is a whole body scan, whole body MRI from the top of the head all the way down to the toes. And these toes pop up there. I wish I could make it go slower, but I can't. But it's very interesting because you're making a series of cuts, electronic cuts, all the way down, and they put this together, and you can see all the internal structures. And the thing that I find fascinating here is, I will say again and again and again, that under the surface of our skin, we all look identical. Everything is exactly the same. But if you look at the arms and legs, they look just like steaks. Bone-in round steak. So my wife doesn't let me say that anymore at Food City. Oh, look, looks like a cross section of a human leg. They didn't like that. And so she doesn't let me say anything there anymore. Anyway, because our leg muscles look just like beef muscles, because it is pretty much the same thing, as far as the structure goes. If you want to get a good idea of what a cross section of a human leg looks like, go look at a piece of meat with the bone in at Food City or at Walmart or something. So, but it does. This is perfect for showing structures in the body. And all it is about probably 10,000 individual electronic cuts through here put together in this video. So, okay. Now, there are a few more things just to cover here. We are organized, our bodies are organized into various cavities. Things go in places where they belong, like here in our torso model. We have all, this is the abdominal region down here, and all these organs that are laying out on the table belong in there. We have a dorsal body cavity and a ventral body cavity. Our dorsal cavity is the one in the back, and that includes the skull, where the brain is located, and the vertebral column with the vertebral cavity where the spinal cord is located. So you can see cranial cavity, spinal cavity on the dorsal side of our bodies. It is the most protected region that we have. The brain's inside the skull, the spinal cord's inside the spinal column, and nothing is more protected than the brain and spinal cord. And so that makes up the dorsal body cavity. The ventral cavity or anterior cavity, the one in the front, gives you the thoracic cavity in the chest, where we have the heart and lungs and the great vessels, and the trachea and the esophagus, protected by the ribs and the sternum here in the front. Below that, we have the abdominal cavity, where we have what we call the viscera, all these loose internal organs which are held in place by reticular fibers. I think I mentioned that in lab on Tuesday. Reticular fibers form a framework to hold things in place. You know, what keeps our liver up here and our stomach over here on the left-hand side, and the pancreas below the stomach, and why does the small and large intestine weave itself back and forth in the abdominal cavity, and how come it all doesn't slide down to the bottom of the cavity? You know, well, thanks to those fibers. But we have everything in the front. The soft and squishy stuff is all in the front, you know, and the abdominal cavity is not protected by anything. Only the heart and lungs are protected in the front, and the brain and spinal cord in the back. So, and this is if you like good, visual learning, cranial cavity and vertebral cavity, where the brain and the spinal cord are located on the dorsal side, and the ventral side gives us the thoracic cavity and the abdominal cavity, or as they say, the abdominopelvic cavity, because this covers everything. Everything below the diaphragm is the abdomen. So you have the liver, the spleen, the gallbladder, the stomach, the small and large intestine, the kidneys, the urinary bladder, and reproductive structures, all internal. In the chest cavity, you've got the lungs, you've got the heart, you've got the great vessels, and the trachea and the esophagus in the front. So, as protected as they can be. So, there is a dorsal body cavity. Again, it contains the central nervous system. The brain and spinal cord make up the central nervous system. The central nervous system is our number one control system. It's also where us, are located. Our personality, our knowledge, our memories, our skills, our experiences are all in the brain, and processed, and the control mechanisms for movement and thought and activities are all through the spinal cord. And so when I say us, our personality and everything else that goes along with it is in here, and it is the most protected area of the body. And I already said this. There's all the viscera, the internal organs, in the ventral cavity. So. The lungs are inside their own cavities. They're called the pleural cavities. Pleural cavities pleural cavities have two layers. Each one has two layers. One layer is stuck to the surface of the lung, the other is stuck to the chest wall on the inside. The pericardial cavity surrounds the heart. It also has two layers. One stuck to the heart itself, and the other stuck to the heart, to the chest wall. So these organs are suspended in the thoracic cavity. And then, of course, we have the great vessels running right underneath all of this. And I've said this several times, the abdominal cavity, the stomach, the spleen, the gallbladder, the liver, and then in the pelvis, we have the urinary bladder, the reproductive organs, and the rectum. Okay, so here we see a little way, one of the ways of evaluating a patient is to ask them where it hurts. And we'll get into the whole concept of pain later on, but pain is not really the location of pain is not a truthful basis, meaning where it hurts is not always where the problem is. We have this phenomenon called referred pain, but we'll get into that later. But if a patient presents and they have pain in their lower right quadrant, so you can see where the lower right quadrant is there, picture on the right-hand side, lower right quadrant. They have pain in their lower right quadrant, and they've had fever and nausea and vomiting, and they're drawing their leg up, like drawing their knee up when they're laying down. And if you touch them on the lower right quadrant, it hurts. They scream out, that really hurts. What do you think they got? Appendicitis. That's a good diagnosis right there, appendicitis. You know, because all those symptoms together are pointing a big red arrow at the appendix, which is located in the lower right quadrant. It's probably inflamed, probably infected, may have to come out, may have to be treated with, might be able to be treated with antibiotics, but that's the, you know, that might be appendicitis. You know, a penetrating injury in the lower right quadrant, that's easy. They got a 2x4. I don't exaggerate. They have a 2x4 sticking out of the lower right quadrant. It happens. There's not much that doesn't happen. Hasn't been seen. Upper right quadrant, up here. Pain here. What do you think that is? Well, liver's right there. What else? Could be. It's in the right. It's in the correct area. What about gallbladder? Thank you, gallbladder. That's always a good idea too, because the gallbladder is right here, and when it gets inflamed, it hurts and causes nausea and vomiting too, and a lot of gas. Those are sort of the giveaways. But sometimes the pain doesn't stay there. Sometimes that pain travels. So sometimes your patient with gallbladder may have pain in their right shoulder. So this whole chart doesn't do any good. You know. But the classic gallbladder attack, pain, nausea, vomiting, and a lot of gas. Flatulence, as they say. So this is the kind of thing that you would use when you're evaluating a patient and you're seeing them for the first time, maybe in the emergency department, maybe in a physician's office, maybe in the hospital, for whatever reason they're being evaluated. And, you know, well, does it hurt? Where does it hurt? Well, it hurts here, it hurts here, it hurts over here, it hurts here, you know, or maybe it hurts in the back. So at least in the abdomen, from below the diaphragm, you can get a good idea. You know, these are starting points. But you always have to start out very broadly. You know, it probably is appendicitis. It probably is the gallbladder. But our bodies are sneaky, and our bodies will give you pain in areas where it's not supposed to hurt. Person having a heart attack is supposed to have pain in their chest, right? Correct? Okay. Where's the common area? The arm, the left arm, and left arm, yes, left arm, or maybe in the lower abdomen, or maybe in the lower jaw, because the nerves that sense pain in those areas run on the same pathways as pain from the heart. So it's not unusual for your body to say, for a patient to be having a heart attack, but they're not having chest pain, they're not short of breath. Left arm really hurts. Or maybe they have a toothache of indescribable proportions here. Oh, it hurts so bad. Sometimes the toothache is just a toothache, but sometimes it might be something else. So, so when you're assessing a patient using either one of these charts, that's just a starting point. You can't tie yourself into, you know, you got to start narrowing it down. But say, oh, I'm sure it's the appendix. Well, suppose they were opened up and like the appendix is fine, but they've got a bad gallbladder and that's up here. You know, so our bodies don't play fair. Now this other chart, the one on the left, is a little more specific. It's instead of 4 regions, it's divided to 9 regions. It gives you the umbilical region right around the belly button. Everybody knows where the belly button is. And then we divide it up into right and left lumbar, which sort of corresponds to the area of the lumbar vertebrae. We have the right and left iliac, which corresponds to the location of the iliac arteries and veins. And up here we have the right and left hypochondriac. Now, depending on whether you are working in the emergency department, whether you're doing a patient evaluation, you would likely have this chart already there. And you would probably likely just check off where they're reporting pain. So, so it's either one of these are going to work for you in any kind of healthcare. Forget that. Now, something else that we have in our bodies is we have a series of membranes to lubricate, because our bodies hate friction. I mean, we really hate friction. If you rub your hands together for just a couple of seconds, it's going to get warm real fast. Imagine that constantly going on every time we took a breath. That would hurt. Or every time our heart contracted and beat, that would hurt. You know, we don't like friction. So we lubricate all of our organs that have to move with this goopy fluid, either called mucus or serous fluid. Mucus is what we call it when we're exposed to the outside. So lining the inside of your nose, you're going to have mucus. We call it mucous membranes. And when I showed you the goblet cells the other day in lab, I think the goblet cells secrete mucus. If your nose is running, it's mucus. Your nose runs because it's trying to remove an irritant. So the saliva is essentially mucus. We have mucus lining our esophagus and lining our entire digestive tract, all the way down to the end. We have mucus around the reproductive organs, in our mouth, in our nasal cavity, whatever. Internally, that mucus isn't called mucus anymore. It's now called serous fluid. It's the same stuff, only it's not exposed to the outside. So we lubricate the lungs on the outside of the lungs. So when the chest expands and the lungs expand with the chest, there's a layer of serous fluid between the surface of the lung and the chest wall. Sort of like, think of like a peanut butter sandwich. You know, how the two pieces of bread stick together. The lungs stick to the chest wall like that, and the mucus, the serous fluid in between is like peanut butter. It eliminates any friction that's going on here. You know, and so when things move, we don't have any kind of irritation. We always call the surface of we have two types of serous membranes that secrete this fluid. We have the parietal layer, which is stuck to the body cavity wall, like the thoracic cavity. We have the parietal layer, and we have the visceral layer, which sticks to the viscera. And in between is a layer of serous fluid, mucus, if you will. And that lubricates and eliminates any friction in the body. So we don't want to have friction when we breathe. You know, there are occurrences where the lung cavity is opened up and that fluid isn't there anymore, and it hurts to breathe, and it irritates the lungs, and they make crinkly sounds, crackling sounds that you can hear. You know, we don't like that because it hurts. And you know, our bodies don't like friction, and our bodies don't like pain. Okay, so here are the membranes that we would see. We would see on the heart we have the pericardium. On the lungs we have what's called the pleura, and we have the peritoneum, which surrounds the abdominal cavity. Both of them are double layers with a visceral and a parietal layer, and there's a big glob of serous fluid in between, so there's no friction. Because I mean, think about friction in your abdominal cavity. We eat something, it goes into our stomach churns around. Our stomach can churn in 3 different directions, and then it goes into the small intestine. You've got 20 feet a small intestine that's moving and pushing and shoving and squeezing food as it's going through, as we're absorbing it. And, we get gas, we get distended, we get uncomfortable with gas. Imagine how much more it would hurt if we didn't have anything fighting friction in there. You said, I feel bloated today because I'm all gassy. Well, suppose you had like 3 bran muffins and a bowl of cabbage for breakfast. I don't know. I'm exaggerating. Nobody eats 3 bran muffins and cabbage for breakfast. But if you did, you would feel uncomfortable because your small intestine would be distended. Imagine how much more it would hurt if there wasn't a serous layer there to keep it from rubbing against the wall of the abdomen and causing pain. So, because things are moving all the time in our bodies. Yeah. And this is supposed to be an example of how you can demonstrate the double layer membrane effect here in the heart. If you take a balloon and make a fist and push it down the balloon, you will create something that looks like this and give you a double layer with a space in between. It doesn't. The idea is great, but every time I tried it, but it's not a bad idea because your heart's about the size of your fist. And if you would have 2 layers around the heart. You have a visceral pericardium and a parietal pericardium, and we have fluid inside there. And that fluid lubricates the heart so it doesn't hurt every time it contracts. So it's, I've seen that type of illustration since I was an undergraduate. And it's a great illustration and a great example, but, every time I've ever tried it, it didn't work. Usually the balloon would like fly off or something. So anyway, but that's the point of having the double layer. Ooh, and that, right on time too, is the end of chapter 1. So, okay, let me do this. And anybody have any questions on anything? Okay, then I'm going to get us out of here.